Just a few ground rules before I introduce our colleagues today. Please stay on mute throughout. It keeps the disruptions down to a minimum. And as a reminder, for questions and answers to our presenters, we always post these in the chat function. And then as the moderator, I will pull those and query our panelists. We have a different approach today. Recently, we did publish a special issue. So we do have two authors that will be providing 5x5 presentations of their publications. And then our main presenters will speak on spine biomechanics for approximately an hour to hour and 15 minutes. And then we have a presenter speaking on contextual factors. So today's is a little bit longer, but I think the content is actually quite good. All right, so I'm going to get us started, try to keep us on track. Our first presenter, which will be speaking on a 5x5 presentation, is Kesava Sampath. Dr. Sampath is a physiotherapist and an osteopath. He's a senior academic staff member at Wintec University in New Zealand. His research specialty involves the role of manual therapy and influencing the neuroendocrine system. So Kesava, you want to go ahead and share your slides and we'll hear your 5x5 presentation.
So, thank you. I'll share my screen. Marina. Hello, everyone. Good morning, good afternoon, good evening, wherever you are. Thank you, Chad, for this opportunity. I will get tracking as I've got another 4 minutes and 55 seconds, perhaps. So I will get it starting. The topic for this morning for me, for the special issue, we did a systematic review update on changes in biochemical markers following a spinal manipulation. Spinal manipulation or eye velocity low amplitude thrust technique, as some of the professions may call it. We all know that it's an hands-on technique frequently used by manual therapists, including osteopaths, chiropractors, physiotherapists. The main reason to do a spinal manipulation is to reduce pain, and we all know that pain is the most common reason why someone is going to come and see us in our clinical practice, but also to improve range of motion, reduce inflammation, and improve function. I think almost all of us here are not interested in the question why spinal manipulation is working, which is probably an interesting question too. But I think most of us here are here because that's been my main research area in the last 8 years. I'm interested in knowing how things worked. This started my PhD journey back in 2016, where I did a systematic review. One of the hypotheses when we started as to how manual therapy may work was based around that spinal manipulation could result in activation or liberation of various biochemical markers in the tissue, in the peripheral nervous system or the central nervous system, such as substance P or TNF-alpha, or some endocrine markers like cortisol or pain markers, etc. And we published a systematic review back in 2017 on this effect. And one of the major findings of our systematic review was, yes, there was some evidence, preliminary evidence, that spinal manipulation would result in liberation of various biochemical markers. And it was all good. I did my PhD, did a couple of randomized controlled trials, etc., etc. And recently, in 2023, we were thinking of an systematic review update, and it's been 7 years. And the reason to do an update was that our initial review was widely cited. There was quite a lot of attention on that systematic review, suggesting that our review was still current and topical. And since our review was published, there was quite a lot of articles that was published on this hypothesis, investigating as to how spinal manipulation would work. So we thought there is a possibility that the level of evidence that we proposed back in 2017 could change. For example, whether it could go from medium level evidence to high level evidence, or from high level evidence to low level evidence. And this shift in level of evidence is really important to understand, so which would then either result in more studies, or we could just say, hey, actually we have done enough number of studies there is not much point in doing any more studies here because the level of evidence wouldn't change. So therefore, the aims of this current systematic review update was to investigate whether the effects of spinal manipulation on biochemical markers in humans, and to establish the level of evidence, rather I should say, was to see if there is any changes in level of evidence since we published the initial review. In terms of methods, we followed the robust PRISMA guidelines. The protocol for this review was published back in 2016. It's still available in Prospero. We initially developed a search strategy in collaboration with the librarian back in 2016, but we also did the same back in 2023 to go and ensure that the search strategy is still current and relevant. We did quite a robust search of 10 databases since their inception. And as good practice, we always add 3 reviewers in all the stages of the review, whether it's search strategy or whether it's finding the studies or ensuring getting the studies to meet the eligibility criteria, etc. In terms of studies that's included, we were focusing on randomized controlled trials or controlled clinical trials as our aim is to produce a top level of evidence. In terms of participants, we were interested only in studies done on human beings, and that's straightforward. Intervention of interest was spinal manipulation or HVLA. Comparison or comparator could be any other technique. It could be exercise or it could be mobilization, any other technique compared with spinal manipulation. And outcome measures of interest were biochemical markers. We broadly classified them as neuropeptides, pain markers, endocrine markers, etc., and inflammatory markers. Typical example could be substance P or cortisol, which is a hormone. Risk of bias was done using the quite established and valid Cochrane tool, Cochrane risk of bias tool. And level of evidence or synthesis was done again by a robust, well-established grade tool. This was a bit of a busy slide, so I thought I will use the animation function so you're not going, boom, what's this? And on the right, you can see the PRISMA flow diagram, which is again a very standard protocol when you do a systematic review, breaking down each stages, how many articles were there, and then coming to the last final included number of studies. Initially, in our review, we had 8 studies back in 2017, and on top, with our latest update, where we started from around 1,400 articles or something, we came up with 7 studies that met our criteria. So in total, for this review update, we had 15 studies, of which 9 were included as part of meta-analyses. In terms of risk of bias, I will just make it slightly bigger so I can see. One of the main domains that kind of didn't meet our risk of bias criteria was blinding of participants and the therapist. I think that's one of the domains that's always been debated quite a lot in manual therapy setting. Can we actually blind an intervention provider with a patient? But other than that, all the other domains were okay. And we produced around 7 or 8 forest plots. I'm just choosing to share the main one, which was significant, which had a significant finding, which showed that a spinal manipulation would result in changes in cortisol levels immediately following an intervention. Even though the direction of effect could be either low or high, but it definitely had a change in cortisol levels. So in total, we had 15 studies. We had 737 participants giving us the data. The mean age of participants was close to 30 years of age. The interventions mainly were either neck manipulation, cervical spine manipulation, or thoracic spine manipulation. And the comparator mainly were sham or mobilization. The key outcome measures that were used in studies were substance P, neurotensin, cortisol, epinephrine, norepinephrine, interleukins, TNF, oxytocin, and orexin A. And if you look back at all these chemical markers, they're either involved in pain or they would be involved in inflammation. Overall, we considered the risk of bias to be low. And overall, we found a low level evidence, which is really important to highlight because the level of evidence is really important when we do a systematic review. For this update, we had a low level of evidence that spinal manipulation can influence cortisol levels. But there was no evidence for any changes in substance P or neurotensin or oxytocin, etc. And there was kind of a bit of a change from our initial review. In our initial review back in 2017, we did see some changes for these biochemical markers, but with the update, the level of evidence has changed. Things like applicability of evidence, it's really we consider the review update findings to be crucial for clinical practice. However, we suggest that our findings are interpreted with caution based on the wider prediction intervals. And if you're really interested in prediction intervals, I think one of the main learning point for me was understanding prediction intervals. It's crucial to know what prediction intervals are. And the more wider they are, the applicability of our findings to clinical practice could be challenging, which really points out to the need for more robust studies rather than anything else. The overall quality of evidence was low or very low for some certain outcomes. Again, this is mainly influenced by heterogeneity of the included studies, different population, different settings, different interventions being done, and the wider prediction intervals resulting in imprecision and inconsistency. Potential biases, we could have, the studies mainly focused on studies done in English language. So we could have easily excluded studies that's done in languages other than English. So we would probably strive for a future review that includes studies from all languages. However, the resources available can be tricky and challenging at some times. Therefore, the generalizability and clinical application of our findings could be challenged or questioned based on the wider prediction intervals. But again, this is an update, and what all it points to is could be need for future research, where we could start asking the clinical utility of these changes. Clinical practice in terms of implication, we have to keep in mind the effect of intervention could change, and an individualized approach is still really paramount. In conclusion, we recommend that there are few more well-powered clinical trials that's been done on symptomatic population, especially. Therefore, we can probably perhaps come at a bit more relevant findings for clinical practice. The review update is available at the link provided below. And that's it from me from New Zealand. Thank you for the opportunity again, Chad.
And thank you, Dr. Sampath. It's good seeing you, and thanks for getting up early for this. Let's go ahead and switch out and have Dr. Keter, our next 5x5 speaker. Dr. Damian Keter is a clinician, researcher, and lecturer at the United States Department of Veterans Affairs Medical Center in Cleveland, Ohio. He's published literature and lectures nationally on topics related to pain science and manual therapy. Dr. Keter? And you're muted.
Sorry about that. You guys hear me now? Can you guys hear me now?
Yes, we can hear you. We can hear you.
Okay, sorry about that. I was having a little hiccup on my end here. So I'm here. First and foremost, thank you for having me on today, and welcome everyone joining from all over the place here. We did a what's called a nominal group technique to identify gaps and mechanisms in research on FBM. So I know that technique is not as common to individuals as far as a form of consensus measure, but we'll dive into that a little bit, what we did. But the results really help to frame where mechanisms research in go moving forward. So with that, FBM, what is force-based manipulation, right? So per the RFA, it includes therapeutic application of force. So things like light touch, pressure, massage, mobilization, thrust manipulation, needling, all of those type of things. We know that these techniques are utilized across different professions, osteopaths, chiropractors, a lot of different people use these techniques, which was really important to the format of how we did this study, which I'll talk about here in a moment. We know that force-based manipulation provides clinical analgesia and improves pain-related outcomes. However, the mechanisms behind how this works is not well understood. We know that there's neurological, neuroimmune, neurotransmitter response. Dr. Sampath just got into some of these responses. We know these things occur, but our understanding of which of these things really matter and how these things relate to clinical outcomes, the translational value of these things, is a little limited. So there's definitely some gaps that need to be filled. So with that, the purpose of this study was to identify gaps present within mechanism-based research as it relates to force-based manipulation. So we did a 5-stage virtual nominal group technique. As I mentioned, this is a form of consensus research. It's not as common as things like the Delphi that we hear of, but there's really some benefits to it over those of Delphi and surveys, such as direct communication between the participants and equal representation of the participants in the group. So With that, we're looking for 5 to 9 individuals typically to perform or to create this expert panel. We wanted to make sure that we included individuals from across these different disciplines that we talked about. Some of these things like the osteopaths and chiropractors, soft tissue massage providers, all of those type of things. We identified individuals based on publication history and educational leadership roles as they relate to FBM. We gave these individuals pre-work, okay? So we gave them an outline, a format of what an NGT looks like, and then we also gave them the definition of FBM, and then some articles related to force-based mechanisms or mechanisms of force-based manipulation and how some of these things would be discussed in our session. We then dove into a 2-hour synchronous virtual session with these individuals. Stage 1, we introed the idea of an NGT, talked to them about what the purposes of this study were. Stage 2 was they silently uploaded their thoughts, their gaps that they had, that they had come up with since the pre-work onto a shared document without discussion. Stage 3 is these individuals shared amongst all of us in a round-robin fashion, all of the gaps which they found in these different areas or that they had in these different areas. And then stage 4 was where we started discussing these things. We started refining them, consolidating these things, really coming up with a final list of gaps in all of these different domains that we thought were present within the research as it relates to FBM. We then stepped out of the 2-hour synchronous session and voted on these gaps in the different areas. And we used a 4-point Likert scale with more than 75% agreement, reaching consensus on the different gaps. So what did we end up finding? Well, participant-wise, we ended up with 8 individuals. We ended up with a really nice group here, an international representation across osteopathy, chiropractic, physical therapy, and soft tissue provider, and even a biomechanist was able to participate. So we had a really nice group of individuals here. We ended up coming up with 4 gaps in neurological mechanisms research, with 2 of those reaching consensus, 4 gaps in neuroimmune research, with 2 of those reaching consensus, 7 gaps in biomechanical research, with 1 of those reaching consensus, 2 gaps in neurovascular research, with 1 of those reaching consensus, 1 of 1 gaps in neurotransmitter research reaching consensus, 6 of 9 gaps looking at contextual factors and how they influence mechanisms reaching consensus, 3 of 3 gaps in translational mechanisms research reaching consensus, and 7 out of 7 gaps in other areas reaching consensus. Now, it's obviously beyond the scope of a 5-minute 5x5 presentation to go over all those results, but I really implore anyone getting into this area of study to look at these and really try to identify what these individuals, what these experts thought were some of these really priority gaps in mechanisms research. There were some themes that we noticed across some of these gaps, though. We know that the biomechanical domain had less overall support, with only 14% reaching consensus. Not really sure if that's related to the idea where individuals think it's already been studied enough, or if individuals think it's just not that important, but that had a little bit less support than some of the other area. All 3 of the gaps looking at translational research met consensus, so we know that that's a priority area, is identifying which of these mechanisms really matter to clinical outcomes. The association between mechanistic responses in the different domains, how they interact with each other, the association between dose with mechanistic response, does more equal more response, and things along those lines, as well as looking at the contextual factors and how those influence mechanistic response. They're also investigating how FBM differs for different individuals with perhaps different pain phenotypes or clinical phenotypes. So overall, the results support that there's a complex multi-system mechanistic response to FBM. The results should help to guide future mechanistic studies. And the beauty of it is a lot of these things can be studied congruently. You don't have to pick one of these gaps and just study that. A lot of times you can study these things together. And then I just want to thank the authors and participants. And there's my info if anyone has any questions for me regarding the study.
Thank you so much, Dr. Keter. Great presentations, guys, and thanks for your contribution to our special edition. And thank you, everybody. We realize we had a Zoom bomber there, but we think we've taken care of that. Otherwise, we'll keep everything muted. And if somebody sneaks in that is looking to be more problematic, we'll have them removed. All right, our next speaker and the start of our spine biomechanics component is Dr. Dawn Elliot. And you'll know Dr. Elliot as a member of ForceNET. She is the Associate Dean for Graduate and Postgraduate Education at the College of Engineering and is the Blue and Gold Distinguished Professor in Biomedical Engineering at the University of Delaware. She is the PI and Director of NIH-funded Delaware Center for Musculoskeletal Research. Dr. Elliott's group studies structure and function of fiber-reinforced musculoskeletal tissues such as the disc, meniscus, and tendon during degeneration, injury repair, and therapy. Her multi-scale approach integrates mechanical testing, mathematical modeling, and multimodal imaging, spanning the entire joint to the tissue level to the microscale. Dr. Elliot has had continuous NIH funding as a primary investigator since 2001. She's had over $30 million in funding, has over 170 peer-reviewed publications, and she will have the fortune to also introduce her co-speakers. So Dr. Elliot, the floor is yours.
I'm still new to Zoom. Okay, it's been very exciting with the screams going on. Hopefully there won't be many screams during our talk here. So I'm really excited about our panel, and it's interesting that in the last 5x5, biomechanics didn't have a lot of consensus, and maybe because us folks in biomechanics need to communicate our work and get you all excited about it. So we're going to try to do that today with some of our innovative work. I'm going to introduce each speaker as their talks come up. We'll each talk for about 15 minutes, and then there'll be plenty of time for questions and discussion at the end. The title of this panel is Discovery Innovative Approaches in Spine Mechanics. Okay, see if I can make the slides advance. All right, so I'm going to start off with my talk, which is MRI-based measurement of disc mechanics across the lifespan, and I want to acknowledge my co-authors. Hera and Kyle are both graduate students who really took the lead on this work, and John Peliquin and Edward Slavic are collaborators on the project, and it was funded by the NIH. So low back pain, as many of you know, is a leading cause of years lived with disability globally. But importantly, a very large number of subjects with low back pain have non-specific mechanical low back pain, which means they have pain during some kind of activity, but no structural abnormality that can identify where the source of that pain is. And indeed, routine MRI can't differentiate between normal aging and degeneration and low back pain related pathology. So it's really, MRI doesn't currently alter the course of treatment. So because of the importance of mechanics and motion during low back pain, our objective in this study was to quantify in vivo disc mechanics, and we're going to do it using MRI, and then to quantify the baseline changes in age that happen in asymptomatic populations. So stepping back a minute, what is required to quantify mechanics? So to quantify mechanics, you need at least 2 deformation states or 2 loading states. So we need to impose some internal deformation without disrupting the tissue, and your intervertebral disc is buried deep within the body. Not easy to go in and impose internal deformations without disrupting that tissue. The way we're going to do it in this study is using MRI-based biomechanics, and I'll explain what I mean by that in a bit. But there's other ways to cause some internal deformation or load in the disc. So one option is interdiscal pressure measurements, and then measure pressure under various postures and loading conditions. Another way is discography, where you would insert a needle and inject a dye and look if we can recreate the pain, and also look at the change in the pressures. The challenges with these are they're invasive, painful, and this dyspuncture that you need to do these measures can be initiating degenerative changes. MRI is clearly non-invasive and can be used to identify structural abnormalities like bulging or Schmorl's nodes, but those may not be directly related to the pain. There are disc grading schemes where you can observe the changes in the disc with increasing degeneration. Again, that's also happens in asymptomatic subjects. And there's T2 and T1 row weighted relaxation times, which is a measure of composition. But these MRI measures are static and they don't assess mechanical function and, importantly, can't distinguish between aging and pathology. Finite element models are another way to quantify in vivo disc mechanics, and we'll have a talk on that today. And they're very important to provide information on disc function, but for them to be useful, they need to have accurate geometry, material properties, boundary conditions, and be validated. So we wanted to use MRI to look at in vivo disc deformations, and there's been a large number of labs and investigators looking to do this in the last 5 years or so. I'm showing a few of the papers here where they'll use diurnal loading, which means morning versus night, static axial loading, flexion and extension, elastography. One of our speakers today might talk about that, and standing MRI. So there are several of us teams in the field trying to use MRI to quantify mechanics most recently. So the work of my lab at doing this started with using cadaver discs. And we started by applying load in an inSpinal test device outside of the MRI. So we would apply load and fix the disc at a reference or deformed condition, and then take that system that was fixed with load, move it into the MRI, and acquire a very high resolution image at 0.3 millimeter isotropic resolution. Then we would use some sophisticated image registration software to calculate the internal deformations and the strains in between the reference and the deformed image. So we had a good bit of success doing this in the cadaver disc, and in fact, we applied it to look at the effect of nucleotomy in the cadaver disc. So I'm showing here an image of an intact disc in axial section after insertion of rongeurs at the X and removal of the nucleus material in the middle. And then if you allow that nucleus to redistribute over a couple of hours, it fills the hole, but still has a changed material structure internally. So we looked at the post-nucleotomy using the same techniques of MRI taking at a reference condition at under 10% compression. And what we saw in this study, that the axial strain intact versus after nucleotomy was not very much different, but that the circumferential strains in the annulus fibrosus changed quite a bit. So given our success using cadavers to quantify mechanics using MRI, we really wanted to move into the in vivo condition. So here is the overall loading protocol in our study. So our volunteers come in the first thing in the morning, and they lay at rest to sort of unload their discs for 45 minutes. And then we take an image flat in the MRI, a reference image. So the supine reference is what we use as the reference for all of our other images. Then we put them into an extension posture and a flexion posture within the MRI and acquire images in both of those. We send them off to do their normal daily activities, and then they come back after 7 o'clock at night and take the PM image, again in supine. So basically there's 4 images sets acquired at these 4 postures. So the outcome measures for this study are, first, we segment the disc to get volume. And then from the a T1 weighted flash image, we see good boundaries of the disc. So from that, we quantify the disc height, the wedge angle of each disc, and the AP shear displacement of each disc. We use the standard Furman grading. We get a consensus grade between 3 graders. We do T2 relaxation time in the nucleus pulposus. And finally, we get the overall Cobb angle from L1 to S1. Also measure axial strain that I talked about in the cadaver. So here is the axial strain, representative images of the strain fields in flexion, extension, and diurnal. You can see in the 2 that look like a Pepsi can that on the anterior side, it's negative or positive, and compression or tension on the opposite side. So just like something in bending, one side's in tension, the other side's in compression, and the diurnal strains are quite uniform across the whole disc. I want to point out a big difference, though, between our cadaver studies and our in vivo studies. So I'm showing here 2 images, and if you squint, you might be able to tell that one has less resolution than the other. So in the cadaver, we can scan that cadaver segment for 3 hours. It won't move, and we can get a very high resolution image, and from that calculate 3D strains. In vivo, we have a 10-minute scan time, and so we chose to get a pretty good resolution in the axial plane, 5 by 0.5 with a 3 mm slice thickness. So for what I'm presenting today, we're only going to report the axial strains in compression. Okay, so in vivo disc strains, our first study was to look at a young population, and we just published this in the last year. So in this young population from 23 to 31, we had 8 male and 8 female volunteers. None of them had low back pain. And the results for this young population, the degenerative grades that you get are as you would expect. They're 80% non-degenerated discs, 20% degenerated, but no grade 5 severe degeneration. And T2 time versus disc grade is as expected, that there's a strong correlation between the quantitative measure of T2 time in the nucleus pulposus and the Furman grade or the degenerative grade. If we look at the diurnal loading, you can see that the axial strain in this image was very uniform, and it's about 5% compressive strain. We didn't see any effect of spinal level or sex in this population of young individuals. So I'm showing here the strain magnitude and compression for each level, L1, 2, all the way to L4, S5. The red dots are females, the blue dots are males, and you can see there's no difference between them. And not shown here, but there was no correlation with the T2 time as a measure of degeneration, although you wouldn't expect that with this relatively young population. So that wasn't a conclusive finding, wasn't designed to identify degeneration. In flexion, we looked at, again, the axial strain, and I'm showing here that it goes compressive in the anterior and tension in the posterior. So in the anterior region of the disc, the compressive strain was between 2 and 8%. There was more strain at the lower levels, and no difference between males and females in any of our strain measurements. On the posterior side, we had 4 to 8% tensile strain, and again, there was more strain at the lower levels. So that's what we found for a young population of a small number of subjects. So our next study, and I'll caveat it right now, this is very new. We haven't even finished analyzing all this data. So I'm just going to give you a taste for our findings so far, but we've imaged with the same protocol, 84 subjects, 7 males and 7 females for each decade of age, going from basically 20 to 80. 1 spine per subject, that's all they had, and 5 disc levels per spine. So we've looked at all 5 lumbar levels. And again, I will emphasize that we're still analyzing this data, but we're really excited about it, so I wanted to share it. So let's look at the effect of age on degeneration. So there's nothing surprising here. It's well known that the disc becomes more degenerative with age. And so if you look at the Furman grade, you can see it's highly correlated with age. But what I want you to really focus on is how much overlap there is. There's so much overlap that Furman grade is a very difficult measure to use to quantify disc degeneration. So in the next panel, I'm showing the nucleus pulposus T2 time versus age. This is similar to what I showed before. It's a measure that's used in the literature a good bit most recently, and it's also very correlated, highly correlated between T2 relaxation time and age. But because it's a quantitative measure, even though there's still a lot of noise around it, it gives us more of a picture and measurement of the degenerative level, the degenerative degree of each disc. So looking at diurnal loading, and I'm only going to be reporting mostly diurnal loading effects today, we see on this plot on the left that the percent height loss and the percent volume loss from morning to night is highly correlated. So if the height goes down, the volume changes similarly. And what I'm showing in the other plot on the right is the percent height loss is not dependent on age. So you get about 5% compression from morning to night on your disc and it's not age dependent. We also looked at the change in the T2 time in the nucleus pulposus. Again, we think that is a measure of disc degeneration. As you compress the disc from morning to night, you're going to have water flow out of your disc, so it could be a change in hydration in the nucleus pulposus, and we see that there's about almost a 7% change in nucleus, or decrease in nucleus pulposus T2 time from morning to night, and it's also not age dependent. Looking at flexion extension, we have a lot of data that I'm not ready to report yet. We see that flexion and extension, as measured by total Cobb angle, is correlated with age with a significant p-value, but the effects were extraordinarily small with an R-squared of 0.1. So I'm not even showing the plot because it looks like a scatter plot to me. So what I'll say now is that our strain analyses and our multifactorial statistic analyses of both the diurnal and the flexion extension mechanics are a work in progress. So I'm hoping that maybe I'll come back next year or in 6 months, or you'll see my student give a talk at a conference where or finally read the paper, where we will tell you all about how you can use MRI-based mechanics to quantify normal and hopefully low back pain mechanics. So in summary, for this study, we did non-invasive quantitative evaluation of the in vivo disc strain using clinical MRI scanners. Next, we're going to analyze all of these data across the healthy discs so we can my goal is to establish a statistical model to predict normal disc health that's based on strain fields and subject traits like sex, age, weight, exercise, and then apply these methods and the statistical model of normal to study low back pain patients with the goal of impacting how we understand mechanical low back pain and how we can diagnose and treat it. So with that, I am excited to introduce our next speaker, and then we will have time at the end of these 3 talks to ask questions. So feel free to throw them in the chat as we go along, and then we will all answer them together at the end. And hopefully you'll find a lot of overlap and synergy between these 3 talks. So our next speaker is Deva Chan, and Deva, you feel free to share your screen while I introduce you. So Dr. Chan's an assistant professor in biomedical engineering at Purdue University. She received her degrees from UC Berkeley, UC Davis, and Purdue before doing her postdoctoral research at Rush University Medical Center and the NIH Clinical Center. Her research interests include musculoskeletal biomechanics and mechanobiology and biomedical imaging to assess tissue-level structure-function relationships. And her research has expanded into matrix biology and multi-organ crosstalk. Dr. Chan received an NSF Career Award to examine the role of mechanical stimuli in modulating the turnover and function of hyaluron, a ubiquitous glycosaminoglycan with diverse physical and biological roles in the body. And she also received a DARPA Young Faculty Award to study the role of gut microbiome in altering musculoskeletal structure and function. So I'm really excited to turn the stage over to Deva Chan.
Great. Thank you, Dawn, for that wonderful introduction. Can everybody hear me okay?
Yep.
Yes.
Great. All right. Well, today I'm going to talk about a little sliver of all of that material that was in the introduction, and that's primarily going to be multi-contrast MRI and elastography of the intervertebral disc. This will mostly focus on one of our most recent papers. It's currently under review and in preprint as well, if you want to take a look. And so just to give you an overview of what I'm going to talk about, I'm going to first talk about the interface and the intersection of MRI and tissue biomechanics. This is really where a lot of the work that my group does intersects. And here I include things like quantitative MRI, or also known as compositional MRI, because the correlates to the tissue composition. And then also a technique called displacement encoded MRI, which I'm going to talk a little bit more about. And then for the most part, I'm going to focus on our multi-contrast MRI study of the disc. There we used quantitative MRI and did T1 and T2 mapping, and I'll explain a little bit more about both of those. And then we did displacement encoded MRI using a technique called DENSE to evaluate the disc mechanical behavior under cyclic loading in a way that's very similar to what Don showed earlier in an ex vivo model of human cadaver using human cadaveric disc. And then finally, we do the elastography part of the title, and we used an iterative inverse modeling technique to estimate the relative shear modulus based on these measured deformations. So I'll start with this idea of MRI and how it intersects with tissue biomechanics. And so essentially we have quantitative MRI, which has been used in the past as a biomarker for tissue composition and the various properties of the protons. Because these protons are a source of MRI signal, they often allow us to either directly measure or infer some kind of composition of these tissues. And so that's where the value is in terms of comparing healthy tissues to tissues that might be enzymatically degraded, or either models or case studies of disease and degeneration in these tissues. Often in a lot of these qMRI studies, there's some correlation to benchtop mechanical testing as well, to be able to correlate the qMRI signal to some kind of mechanical property or mechanical behavior or material properties. And then finally, there's this renewed interest in being able to measure how these parameters, such as T1 and T2, actually change both during and after loading. Because as you can imagine, if the water content and the composition of a tissue is altered during loading, that the qMRI biomarkers might be sensitive enough to pick it up. Second on this list of interactions between MRI and tissue biomechanics are the set of MRI techniques that allow for a direct measurement of tissue deformation. Under here, I include a lot of these motion-sensitive MRI approaches. These are often phase contrast techniques, which actually means that you manipulate the MR physics in order to measure directly how each pixel has relocated from one part of the image cycle to a different part of the image cycle. For anyone that's seen cardiac imaging, you might know what I mean in terms of being able to visualize the deformation of the heart in almost real time. Other techniques that are involved with direct tissue deformation almost always are going to involve, right, unlike the heart, most of the musculoskeletal tissues that I work with involve some kind of exogenous loading being required in order to load these tissues. And this will be true whether an in vivo study or an in vitro or ex vivo study. And then finally, there are numerous techniques that I group under elastography. And these are all the techniques that use some kind of direct measurement of tissue MRI, of tissue deformation using MRI. And they use those inverse techniques in order to estimate material properties. What most of us think of as MR elastography actually takes place under very high frequency shear waves that are used to vibrate the tissues. And that vibration of the tissues is proportional to the material properties. But what I'll show today is our use of motion sensitive MRI approaches that can actually be tuned to lower frequencies that better match physiologic loading rates. And then finally, where these might intersect is this entire category of biomechanics work, some of which Don alluded to, where we're able to take measurements and create biomechanical models coming from the MRI-based images. Often images, anatomic images are used for this, and you can analyze the changes before and after, or even before and during loading, if you can synchronize the anatomic images to loading. And the second half, which is the computational biomechanics, which some of the next speaker might allude to as well in her talk, uses image-based morphology, segmentation of those tissues in order to identify a geometry, and then you generate a computational model that allows you to predict what kind of deformations might occur under certain conditions. And together, all three of these interactions between MRI and tissue biomechanics help to describe what I like to call the structure-function relationship, right? Quantitative MRI or compositional MRI gives us an idea of the underlying structure of a tissue. Direct measurement of these tissue deformations allow us to predict some kind of function. And usually we can use computational models and other analysis to establish some kind of relationship between the structure and the function. And so I'll start with kind of more of a history lesson, actually, in terms of compositional MRI or quantitative MRI being used in the disc. And one of the very first studies to look at composition of the disc using qMRI techniques was done by Shatani and others back in 1993, right? So we've known about these techniques for quite a while. And they used 15 discs from humans, and they found that there was a statistical difference when they looked at the differences in T1 as well as T2 as well as water content between the nucleus pulposus and the inner and outer annulus fibrosus. And what really piqued their interest, I think, was the fact that these statistical differences were very similar between T1 as well as T2 and the water content. And that led them to look further into the direct correlations between the two. And they delved further into this relationship with water content in a very interesting way. They actually took these untreated tissues and they imaged them and took the T1 mapping and took the average T1 of these tissues. But then they also dehydrated these tissues and did the same thing. And what they saw was that even with the same tissues, untreated versus dehydrated, that they got a pretty close to perfect correlation in terms of T1 as a relationship with water content. Similarly, they did the similar thing, but the converse for the annulus fibrosus. And here they had these untreated tissues from the inner and outer annulus fibrosus, and then they actually overhydrated those tissues and saw that, again, there was this very sharp relationship between water content and T1. And so it's pretty clear from even, what is this now, 30 years ago, that there's the strong relationship between T1 and water content really lends itself to the ability for the disc to support compression. Another interesting thing that they noted in this study, though, was that when they looked at T2, there were differences in how it related to water content. And so what they saw was that in the nucleus pulposus, which is indicated by the stars, there was a pretty strong correlation with water content, but that correlation dropped off as they looked at the inner annulus fibrosus and then the outer annulus fibrosus. They repeated that dehydration experiment with both the nuclei pulposi and also the annuli fibrosi, and they saw again that this lack of correlation occurs when you drop below about 75% water content in both cases. And so this is very interesting, right? There's a relationship with T2 with water content, but only when the water content is greater than 75%. And so what is this T2 correlated with, right? And it all comes back eventually to my study, I promise. And so around the same time, Weidenbaum and others also did a similar study where they compared normal human disc and various MRI measurements. And here they did something that was also very interesting. They extracted cylindrical tissue samples from lumbar discs to allow them to have more samples. And then they also compared that to proteoglycan solutions to see where those compared in terms of measuring T2. And so with T2, what they saw was that when they compared water content, they had a really good correlation with proteoglycan samples, but that correlation was not as strong when it came to actually looking at the tissues. In addition to looking at water content, they also looked at sulfated glycosaminoglycan content. And so SGAGs are a primary component of the proteoglycans that make up especially the nucleus pulposus and enable the disc to support compression because they draw in water. And so they found here that although the proteoglycan solutions correlated well, the actual tissue samples did not correlate well between T2 and the total sulfated GAG. On the other hand, what they did find was that when they looked at collagen content in the annulus as well as the nucleus, that this had a pretty strong correlation with T2, right? And so even from these early studies, we're seeing that water content significantly correlates to T1, and collagen content is the stronger correlate to T2, although water does also contribute. And in those intervening years, right, numerous other studies have found these relationships with degeneration of the disc, as well as integrating other quantitative MRI measures such as T1 row and T2 star. And all of these are in some way correlated with either the mechanics of the disc or the degenerative grid, or even the incidence of low back pain, as Dawn's group showed. And so now I'm going to talk about the other half of our study, our multi-contrast study. And this one is going back to the biomechanics side of things, displacement encoded MRI. And as Dawn noted, we need two different configurations in order to measure how tissues behave under loading. We need some kind of reference where they're usually unloaded, and some kind of current configuration or comparison configuration during which we can evaluate how those tissues deform. In our case, we use a technique called displacement encoded MRI in order to measure this. And what that means is that we actually manipulate the MRI physics in order to be able to encode the position of a new pixel location, right? So for example, this pixel on the bottom right here moves to a different location, and because it moves to a different location, it sends out a different signal altogether, not just in the magnitude, but in the phase component of the data. And so when we look at that MRI data, we can extract directly these displacements in the X direction, Y direction, and if we were doing this out of plane, we could do this in the Z direction as well. And we're able to take these displacements, which give us a change in location for every single pixel within the tissue, where we take those displacements and we're able to calculate the overall strains or the full field strains inside a tissue of interest. And so now we're finally ready to talk about this latest study, right, where we loaded a disc inside an MRI. And in that disc, we are able to image the coronal and the sagittal planes. And we performed also T1 and T2 mapping within those planes. We potted the L4, L5 motion segment into these end plates and caps. And within these end caps, we could actually remove one of the pins in order to change the loading regime from compression to bending. And so we had compression at approximately 1/2 body weight, and then we adjusted the bending so that it generated a 3 Newton moment bending moment in the anterior direction. We synchronized that with our displacement encoded imaging, and we also took sagittal and coronal measurements of the displacements. And so what we find are that under compression and bending, we actually see heterogeneous full field strain maps within the disc. And again, these are per pixel. And we actually see that these are slightly different when we do our compression mode versus our bending mode. And you'll notice that in the compression mode, the strains aren't evenly distributed. And so we think that even the most minute configuration differences in how we pot these tissues might lead to a slight extension rather than a direct compression where it's perfectly balanced between axia or the anterior and posterior end. Whereas on the bending, because we are already loading on an eccentric axis, we already see the higher strains on the anterior side. And so we compared all of these to the T1 and T2 mapping. We divided each disc into 15 regions, and we compared across all of our discs across each of those 15 regions. And so this is a lot to take in, so I encourage you to just look at the paper. But in general, we saw correspondence between the T1 and T2, and it was strongly dependent on the direction of the strain values because those were different when we loaded under compression versus under bending. And so finally getting to the inverse modeling, right, we had displacement fields that are measured experimentally as well as computed displacement fields from a finite element model. And we iterated that finite element model until we minimize the gap between our experiment and the model itself. And the things that we iterated within that model are actually the relative shear modulus. So we tweak the shear modulus as a function per pixel in these images until they give us a finite element model that produces a similar displacement field. And so under compression, we see that we get a very different mapping of relative shear modulus than under bending. And so future work for us is still going to be to resolve how we can take two different loading regimes and be able to map it all back to the same model so that we actually get a better approximation for our better elastographic approximation for our discs. And so, of course, I have to acknowledge that there's some limitations and assumptions here. We're right now working with only 2D strains. And of course, we're treating the coronal and sagittal right now as independent. And so when we compare all these, We find that the coronal and the sagittal have some correlations, but they're not perfectly correlated with each other, nor with the coronal or sagittal measurements of T1 and T2. And of course, that means that there's still some variables that we need to consider beyond just the content and the total displacement. So in summary, we did multi-contrast or multi-parametric MRI that included multiple ways of evaluating the structure-function relationship. We performed elastography based on that displacement-encoded MRI, and we hope that in future directions, we're going to be able to better integrate multiple slices or even 3D slices, and then be able to actually integrate the qMRI as a scaling factor when it comes to predicting our elastography measurements. So thank you again for your attention, and I'm happy to direct this to our next speaker. Oh, John, it looks like you're muted still.
Thank you very much. All right, so our third speaker in this session is Dr. Grace O'Connell. And please do put questions in the chat as it goes along, and we'll take care of those after Grace's talk. So Dr. O'Connell is a professor in the Department of Mechanical Engineering at UC Berkeley. She's the director of the Berkeley Biomechanics Lab, and her research interests are in soft tissue mechanobiology and tissue engineering. Dr. O'Connell received her BS in aerospace engineering from the University of Maryland and her PhD in bioengineering from the University of Pennsylvania. Her research group uses computational modeling and experimental approaches to study the effect of aging and disease on tendon, ligament, cartilage, and disc. And she has received many awards, including the Y.C. Fung Young Investigator Award, NSF Career Award, and was recently inducted into the AIMB College of Fellows. So with that, I will turn it over to Grace.
Thank you very much for that introduction. I'm really excited to be here today to talk a little bit about how we're using finite element modeling to predict tissue failure at a tissue scale as well as a disc joint level. And I think the previous two speakers did a great job to give some background that will be helpful for this talk as well. So when we're looking at creating finite element models, we have to include a lot of different information into this black box model. So we have equations that we select to reflect the tissue mechanical behavior. We include a lot of the lab data that was even presented by the previous two speakers, data that we get from the literature, as well as data collected from my lab, whether it's biochemical composition or mechanical function under compression and bending, and how that changes with age and degeneration. And then we also include things, or we can include things from the clinical side. So how well our models predict what clinicians have observed with degeneration and with injury, and ideally to include patient-specific information. So as with one of the previous speakers mentioned, taking MRI scans to be able to get patient-specific geometry, or using T1 row or T2 mapping to be able to know the exact composition in the disc and how that changes. So all of this information can be combined together to create a computational model, a finite element model, to assess loading conditions and to look at how different treatment options may impact of remaining tissues. So we hope that this can become a two-way information stream with clinicians once we have this information to be able to provide that, or with other stakeholders, for example, insurance companies looking at better understanding how workers and factories are loading their tissues on the job. So the way that we've approached this is a multi-scale modeling approach. So we started at the subtissue level with what we know about the tissue, that it's fibers embedded with an extracellular matrix. And I'll talk a little bit about that model development. And then we worked our way all the way up to the joint to look at modeling a single bone-disc-bone motion segment to look at how failure might occur in that segment. So for this, we really needed to use information about the composition and how that composition changes radially throughout the disc. So we have in the annulus fibrosis, we have a very highly aligned collagen structure with gags throughout and a high water composition. And we know that this changes with age and with degeneration, starting in the nucleus pulposus and working its way out. And so all of that information then helped us to build this model and to inform that. And then we can also use information from the literature and some of the information that we just saw presented here of looking at when we simulate compression into the disc, how does it respond mechanically and how well does it match what has been reported in the literature. So at the tissue level, one thing that I want to highlight about the modeling approach that we're using, because finite element models have been used for the disc since the 70s, and a lot of the equations that were developed or used were really developed to study hyperelastic materials like rubber, natural synthetic materials that don't behave differently depending on the water content, which is particularly important for biological tissues. And so our approach used a more structure-based approach where we actually modeled the fibers as a separate material within the extrafibrillar matrix. And we can do this because of new technology through FE-Bio software, which allows us to include mathematical models that specifically describe biological tissues and the water content within the tissues. So what this really means is that now we have model parameters that can be directly linked to water content and to gag content, as well as fiber stiffness. So that's pretty unique. And as we've seen in the previous talk, we can get water content in vivo from T1 row and T2 mapping information. So I want to share today 3 short stories about how we've used this model to predict failure at the tissue level and 2 at the joint level. The first one was to look at tissue failure with increased glycation. So with the increase in diabetes and type 2 diabetes, we know that there's an increase in advanced glycation end products or AGEs, and that people with diabetes have higher rates of tissue failure. This can be in the disc, it can be also tendons and ligaments. And it is thought that the increase in this tissue failure is due to an increase in the crosslinks with AGEs. And in the disc, we also see AGE accumulation increase with age. So we did this first experimentally. We can increase the glycation by putting the tissue in a high sugar bath. And what we saw was an increase in tensile modulus. Mechanically speaking, this actually seems like a very good thing because you want your tissues to be stronger. So it doesn't really match what clinically we see where there's increased failure of these tissues. And so that's where our model actually came in handy to actually look at what's occurring between the fibers. If the fibers are stiffening, what's happening at that matrix and the stress in that matrix. So what's shown in this heat map is a healthy control, where the red actually is aligned with where the fibers are. So the fibers are under higher stress. And then the glycation 50 represents a tissue that would have a higher glycation, for example, a simulated diabetes. And what we see is that the stress increases both in the fibers, but that's okay because the fibers can withstand that additional stress. However, the stress is also increased within the matrix itself, the surrounding matrix. And that's a bit more problematic because one, that's where the cells are embedded. And so they respond to high stress. And we also saw that when we included failure thresholds, that a good portion, over 75% of the matrix would experience damage or microfracture, which can accumulate over time. And in the body, this would mean that damage could accumulate and start to spread throughout the tissue, which we think helps to explain that difference between what we see in the bulk tensile modulus and what is seen clinically with an increase in tissue failure, such that the tissue failure may be actually starting at the matrix and where the cells are experiencing the load. When we developed our model, we included a lot of experimental data from the literature. And once we convinced ourselves that it was it was a good model at the tissue level. We then wanted to take the same approach to the joint level to see if we could replicate joint level mechanics. And to do this, we looked at those material properties that we can change, that were linked to proteoglycan content and linked to water content, and changed that throughout the spatial area of the disc. So the nucleus pulposus would have a higher water content and a higher GAG content, and then the inner annulus fibrosus would have a higher GAG content, and that would actually decrease as you go towards the outer annulus. And so then we allowed the material to swell in our simulation, and we saw this bulging like a normal healthy disc might experience, where the boundary conditions of the annulus fibrosus actually restricts the swelling of the nucleus pulposus. And anyone that's cut open a healthy intervertebral disc in the laboratory knows that the nucleus pulposus starts to swell outside of that space once that cut happens. And that's what we're actually seeing here, is that residual stress that is starting to form. So as we want to simulate degeneration, now all we need to do is change a parameter for the GAG content. And we know how the GAG content changes with degeneration. And if we had patient-specific information about the GAG content or the T1 row, the T2 mapping, we could specifically do that. And what we observed in the simulation of degeneration was a decrease in nucleus pulposus swelling capacity. And this resulted in a decrease in disc height, which was really exciting because we know that we see this clinically, that there's a gradual decrease in tissue and in disc height. And this is largely just in early degeneration attributed to that loss in water, and probably similar to the diurnal changes that Dawn had mentioned earlier. And what was also interesting from this is we saw inward bulging of the inner annulus, which was not expected, but it matched pretty nicely what Adams reported in his book on disc biomechanics. And one thing that was mentioned in Dawn's talk was this shift in swelling. She mentioned it after nucleotomy, but we also saw this sort of behavior when the nucleus pulposus was no longer able to swell to its previous capacity. The annulus fibrosus, which still has some swelling capacity, took over and increased in volume due to that. So to be able to predict failure and to study joint failure, we need to apply loads here. So that was our next step. And with computational modeling, we are very flexible in being able to apply a range of loading situations. In the laboratory, when we apply loading, we're very restricted, and most of the loading conditions are usually applied along the axis of the center of the disc, which doesn't necessarily represent how we load our spine naturally. In vivo loading is due to muscle-driven contraction. And so if you think about flexion, there's many different ways that you might apply flexion to the disc joint itself. There's differences in that length, how far in anterior that the muscle may be applying that force, that moment arm there. So to account for this, we did a range in our model, in our simulation. We did our free swelling step, then we applied compression, and then we applied flexion. And then the thing that we needed to determine here is, where will that rotation be for flexion? And since we don't know what it is in vivo, we know what it is in the laboratory. It would be case A, where it's along the center of the disc, aligned in the center of the disc. And so we did a broad sweep that went out as far as 5.5 centimeters anterior of the disc to look at what happens with flexion and what happens to the disc strains and stresses as you go from the in vitro condition to something that's an in vivo condition. So for this data, it's a double y-axis, so I'm going to walk you through it because it can be quite confusing. We looked at a couple of things. We looked at the average fiber stress, and then we looked at the failed elements. So the failed elements are going to be shown by the circles here. And as you can see, in under just compression, the fiber stretch, it's not high enough that any of the fibers would expect to experience failure. And we've seen that repeatedly in the laboratory, that you can't cause disc failure under just compression. But as we apply flexion, going from left to right here, we see that the fiber stretch starts to increase, and some of the fibers start to get into this gray zone, which is the predicted failure area. Within the torque-driven flexion kind of simulation, which is representative of how researchers apply flexion in the laboratory, we see failure that might be predicted at the bone disc interface, which is not where we really see failure occurring for herniated discs, but it does match very nicely with what we've observed or what others have observed in the literature. As we further move that axis of rotation anterior of the disc, we see some really interesting findings. First, that failure initiates in the inner annulus fibrosus, shown by the asterisks here. And then as that continues on, that failure point starts to transfer more towards the outer annulus fibrosis. And this is actually very nicely representative of what you expect to see in vivo, where you have bulging that occurs at that nucleus pulposus inner annulus interface and starts to push outwards. And so this project was of interest because we're looking at how do we help better understand what type of work conditions put people at higher risk for disc herniation. But then the last little study that I want to talk about is how we can also use that disc model to understand treatment options for scoliosis. So after I presented that work at ORS a couple of years ago, Matt Helsinki, who is a clinician down in Arizona, reached out to me about a kyphotic porcine model to look at tethering to treat scoliosis in adolescents. And so in this, the tethering treatment has been greatly successful in correcting spine deformities in animals, but it hasn't been very successful clinically when performing this on adolescents. And so in this tethering process, you apply attention to correct that deformity. And the hypothesis that we were testing here was that this process may actually be applying too much compression on the end plate, resulting in very little simulated growth. So we applied our model. We first created our disc model such that it had a deformity, and then looked at what kind of loads would need to be applied to correct that deformity, to create a near flat disc. And what we saw with this is that you do see stress gradients in the end plate with very high negative compressive stress gradients. So that matched Matt's hypothesis. And when we looked at this compared to in vitro work on cell mechanics, when you apply compressive stress to cells, it actually inhibits the growth. So over 50% of the elements within the end plate have predicted arrested growth due to the overcompression in these discs. And so we can change parameters. For example, we can look at what if the disc is more flexible, essentially a younger, healthier disc, similar to what you might see in the healthy animals. And then we see this change in the stress gradient across the end plate. In particular, you start to see a very reduced area that has this higher compressive loading. And so we actually predict that some areas might experience growth, and very little areas, less than 5% of the elements in the end plate, would experience predicted arrested growth due to compression. And we were excited about this early results. It was just presented at the recent ORS, and we're still working on the data collection and analysis. But early results also agreed with the animal model itself. We're looking at end plate growth and how much the end plate moves from one end to the other end within two weeks, and seeing that there is a difference from one side to the other. So to summarize, what I've shared today is that we developed a model from the subtissue level to the joint level using experimental data and disc composition information. And we can use this to simulate what happens with degeneration based on known changes with GAG composition throughout different regions of the disc. We could also simulate disc failure, looking at what happens with changes in different types of flexion and magnitude in that in that loading condition. And then lastly, we also looked at surgical options in terms of tethering. And this is a new exciting pathway that my lab is going into. And so with that, I'd like to thank my all of my students that really helped with this work and my funding agencies that helped contribute to it and keep it going. And I'll end there, and I look forward to addressing any questions that you all may have.
Wonderful, terrific presentations. The artwork involved, I'm quite jealous. Very nice. We have been populating some questions. Just to give you specifics, we'll take questions just to be on time, since we do have one more speaker up until 2:25. And so our first question is actually to Dr. Elliot. What challenges exist in doing larger scale, perhaps hundreds of patients, retrospective in silico finite element studies?
That's a whole career right there. So retrospective is tough because most of the MRIs that have been performed there's been no deformations applied, so they're just supine. We can't really extract mechanics or the compositional T2 times T1 times from the retrospective. However, what we are working on is how can we shorten our scan times and shorten the number of different postures or permutations that we do to make it less onerous for the subjects to participate in the studies. Because right now, the study I'm just talking about today was, 3 hours long, and you have to come back at the end of the day. So it's just not feasible to do that on a very large population. But we think as we develop these techniques and shorten our scan times and refine our models, that we'll be able to do more populations and more subjects with less volunteer challenges, I'll say. And finite element models are wonderful because you can do any kind of permutation you think is reasonable and see what the outcomes are. So, there's just a number of studies you can do with a good finite element model.
Wonderful. This next question is for Dr. Chan. If looking at an MRI does identify differences between asymptomatic and symptomatic individuals via stress loading differences, are we expecting these differences to normalize as individuals recover?
That's a great question. I think very much the stresses we might measure externally are going to be dependent on the way that we load them. So I think that's probably one thing to really consider is, even if we're looking at that one disc, when we load a full person from externally, that load distributes in a very different way. And so that might actually change over time as the person recovers. And so you might see changes in the disc that don't actually amount to a change in mechanics or even a change in composition, because the way that the loads distribute through the body has changed because of adaptations elsewhere. So it's actually a really tricky question to be able to answer because we don't know yet. And I imagine that the human body is dynamic enough to be able to make those adjustments without, it completely showing in just one disc.
Wonderful. Thank you. Dr. O'Connell, this question is addressed to you. Do you support Dr. McGill's premise that the lumbar disc has a finite amount of flexion before failure, or is this a possible false premise in a living, breathing human with a fully functioning nervous system?
That's an interesting question. So I deal with a lot of cadavers and they don't complain about the flexion. But I do think in vivo, we have other tissues that provide stability and support. So I think the ligaments play an important role to that you might have failure that occurs there or a pain response that would occur there before fully flexing in.
Okay, thank you. This question is addressed to Dr. Elliot and Dr. Chan. What effect does supine versus prone positioning of the body have on a quantitative MRI of the spine, as the images are most often acquired in supine, but we spend most of the waking day prone or standing, and that's a loading environment?
So I'll take a shot. I think one of the things we didn't talk much about today is how viscoelastic the disc is. And so the loading, there's this initial effective load, and then there's this time-dependent decay. So because, well, for example, in my study, we did morning and night, and you see that there was a change in diurnal. I think immediately, if you stand up, there will be a change, but if we're doing a back-to-back comparison, you're going to capture a large part of the effect of standing all day, even though you're laying flat on the MRI bed. There have been some standing MRI studies, but they're much lower resolution, so they're very hard to do because of the resolution challenges. So you're not going to be able to get the very fast effect of a change in load, but the effect of the change in posture or the diurnal effects, I think you can capture when you're lying flat.
I think that's a great answer. I think the only thing I can add to that is that with quantitative MRI, we also have to take care that there's a lot of variation between even the scanner that you use. So there could be the same person with the same properties on a open MRI standing up versus something lying down, and you might actually get different measurements because of the hardware and not actually changes in the tissue. So I think there's a lot there that's baked into it, and not only including the actual properties of the tissue changing with posture.
Thank you. And this one's for Dr. O'Connell. Do you believe that the increased stiffness due to glycation of the connective tissue can be responsible for myelin degeneration due to alteration of the mechanical environment around the axons inside the nerve?
Well, within the disc itself, there's not that many nerves, maybe at the end stage degeneration. But I do think that the increased stress will change how the few cells that are in the annulus fibrosus and the nucleus pulposus will respond and cause a degenerative cascade. So more tissue remodeling to occur from that.
Thank you. Next question goes to the panel. Currently, we are making great strides in increasing our general understanding about discs. Will this be enough to inform clinical strategies for most people, or do discs behave differently in different people and therefore will require a personalized evaluation?
I'll take a shot. I think personalized is going to be required. I think, if you just look at any of our data sets, there's such a wide variability across the population, even within one age group and definitely across ages. So I think we need to be informed about what an average typical disc does, and then modify our models, whichever model we're using, to be more personalized based on whatever data we can get on that is personalized.
Well said.
Yeah,
You
I
are
would agree with that. I think personalized is the way to go, but it comes with a lot of challenges. And I think we will continue to learn things that can be applied more broadly to improve things.
Thank you. We're going to finish up with this one. This goes to all panelists. What do you think is the best or most feasible way of validating finite element models when the subject is a patient as opposed to a cadaver or cell bones, which are easier to use for validation?
Validating models is one of the biggest headaches right now. And I don't think you could validate it for an individual patient. So what we do is try to get as much data as we can from the laboratory or from clinical observations and run our models to see how well it matches all of those different things. So can we understand how changes in an experimental test setup changes the mechanics, and does our model replicate that? I think right now that's the best that we can do. And then when we do develop those patient-specific models, we have that backing and belief that we were able to replicate all of the other previous stuff and allow us to move forward with that information.
I agree with that. I would add that we're going to try to use our in vivo MRI deformations that I talked about to validate finite element models based on matching the strains that we measure versus the strains we predict. But like Grace said, it's very difficult because of the complexity of the models at each microstructural scale and how all the substructures work together. Sawbones are a lot easier.
All
So are
right, well,
cadavers when they don't complain.
Yeah.
well, once again, our speakers have exceeded our expectations. So really well done. And thank you to our audience for fantastic questions. We'll now transition to our last speaker of the day. And this is Dr. Giacomo Rossettini, who is an Italian physiotherapist and researcher in the area of musculoskeletal pain and manual therapy. He is a lecturer at the University of Verona and the Universidad Europa de Madrid. His main line of research is around placebo, nocebo, and contextual effects. And I might add, he's probably one of the world's most renowned experts in contextual effects. So please welcome Giacomo.
Thank you for the presentation. Okay, thank you, Prof. Cook, for the presentation and the invitation to give this talk. It is a pleasure to be here for me at the ForceNET Winter Symposium. And today I will talk about how contextual factors and about their importance for clinicians. As mentioned, I'm an Italian physical therapist and I'm involved in clinical research and teaching. And I come from Verona, a city in the north of Italy that represents the city of love of Romeo and Juliet. And if you have never visited, I suggest you to do. So before starting, I want to declare that I have no conflict of interest for this speech. And I have organized my presentation into three main sections. Firstly, we will analyze why contextual factors play a role in musculoskeletal care and manual therapy. Next, we will discuss their definition and constituent dimensions, mechanisms of actions, impact on outcomes and treatments, and offer implications for clinical practice and research. Finally, we will conclude with the take-home message. The premise with which I want to begin this speech is that contextual factors are an unavoidable component of any treatment available to clinicians dealing with musculoskeletal care and manual therapy. They are always present when administering both hands-on treatment, such as manipulation or mobilization, or hands-off treatments, such as exercises, or when we use needles or physical agents. So, instead of wondering if they exist and wanting to limit or control them, we should understand how we can use them in our clinical practice for the benefit of our patients. Contextual factors were recently defined in the international consensus in which I participated. In the slide, you will find an excerpt of the final shared definition. Contextual factors are components of all therapeutic encounters and may constitute the entirety of the perceived effects of the intervention itself or be additive to the effects of interventions such as pharmacological and non-pharmacological treatments. They are perceived cues that affect both the patient and the practitioner and can arise from previous experiences and immediate dynamics within the encounter or a combination of both. From a clinical perspective, contextual factors fall into 5 broad categories of dimension that you see represented in this graph. On the one hand, we have the characteristic of the clinicians with their professional reputation, appearance, beliefs, and behaviors. On the other hand, there are the patient's characteristic with their expectation, preferences, and beliefs and previous experiences. Between the patients and the clinician, there is a relational dynamic in terms of verbal and non-verbal communication. In addition to the relational component, also the treatment characteristics play an important role. They represent the rituality of the treatment that we administered. Finally, the fifth dimension is represented by the characteristic of the healthcare setting within which the encounter is being delivered, such as the environment, the architecture, and the interior design. Well, all these 5 dimensions interacting each other influence the overall therapeutic outcome. The question we have to ask ourselves is, through which mechanism does this happen? And I will tell you about this element in the next slides. Contextual factors have been studied for the ability to induce placebo and nocebo effects, which represent the effects of the psychosocial context around the therapy. And to explain how this occurs, I want to start from a clinical example. This illustration shows a common clinical encounter in which patients with musculoskeletal pain receive a manual therapy, such as a manipulation or a therapeutic exercises or an ultrasound rehabilitation. During the administration of the therapy, patients are influenced by the specificity of the treatment, but also by various psychosocial cues, such as the words of the clinicians, the sight and the sound of the healthcare devices, the smell of the hygienic, and the taste of the gloves, for example, when we are doing an intrabuccal mobilization for a TMJ dysfunctions. Well, all these cues influence the patient's perception, shaping their experience in a positive or in a negative way, triggering placebo or nocebo effects. Thus, the positive use of contextual factors can produce placebo effects. When used negatively, it produces nocebo effects. And the clinical effect of contextual factors can be explained through conscious and unconscious mechanisms of action, such as expectations, learning processes, personality traits, mindset, even if genetics. However, among the various psychobiological theories, expectation, classical conditioning, and social learning are the most widely accepted. Expectation is a conscious phenomenon through which patients expect that something will happen in the future. We need to consider patients who are waiting to receive a joint manipulation for the cervical spine. Well, they will predict a positive therapeutic outcome by evaluating all the contextual factors around the therapy we offer as a clinician, such as our words of behavior. Instead, the classical Pavlov conditioning is an unconscious phenomenon concerning past events. In fact, patients learn over time to associate a certain therapy, such as a joint mobilization of the lumbar spine, with specific contextual factors, such as the rituality of the technique created by our touch or by the popping sound of the technique itself. It can produce a certain outcome which can be positive or negative. Patients can also learn from others. They can learn, for example, from the positive or the negative experiences of other patients, family members, friends, or from information on social media or blogs. But how contextual factors work in practice? I will use this image to explain its mechanisms of actions briefly. Whenever patients interact with the healthcare context, they are always influenced by the 5 contextual factors. And these elements are encoded by the patient's brain, who interprets them and provides an evaluation and the prediction of their meaning. If the interpretation is positive, placebo effects are triggered. If the interpretation is negative, nocebo effects are stimulated. And these effects are sustained by a cascade of psychoneuroimmunoendocrinological events at the multiple levels of the central nervous systems in terms of release of neurotransmitters. For example, negative contextual factors can activate the release of cholecystokinin and the deactivation of the dopamine and the opioid system. Instead, the positive use of contextual factors can facilitate the release of opioids, cannabinoids, endocannabinoids, and dopamine. Also, different brain areas are activated. For example, the dorsolateral prefrontal cortex, the anterior cingulate cortex, the grigio-periaquedutal gray, and the dorsal core of the spine are influenced by the context. And all these specific neurological pathways translate into changes in clinical outcomes. And using musculoskeletal pain as an example, if the context offered is positive, the patient will perceive a relief of symptoms. Instead, if the context offered is negative, the patient will have an aggravation of symptoms. Contextual factors interacting with the treatment specificity are able to influence more the patient's subjective outcomes or the illness dimensions than the objective outcomes that represent the disease component. Pain, disability, experience, satisfaction represent examples of outcomes most influenced by contextual factors. However, not all the changes of therapeutic outcomes are determined by contextual factors or by the specificity of our treatment. In fact, several confounders can explain the improvement or the worsening of patients' clinical condition. And examples are presented in this image, such as the natural history of the disease that can explain the fluctuation of symptoms, the regression towards the mean, which represents a statistical phenomenon, the bias of judgment and reasoning of clinicians and patients who very often are led to overestimate the results, or the unidentified co-intervention, as in the case of patients with sciatica who undergo manual therapy and concomitantly receive cortisone. Another question we should ask ourselves is what is the weight of contextual factors in influences the outcome? To understand this, we must mention Dr. Beecher. He was a frontline doctor who, during the Second World War, treated soldiers without morphine. In that dramatic situation, he noticed how the mere introduction of a needle into the skins of patients without any drug created a reduction of pain. And in the following years, this observation increased the interest towards contextual effects. And for a long time, it was common opinion among the scientific community that about 33 to 35% of the total therapeutic outcome depended on the contextual component. And even if it might seem limited, it is actually not, because it is a component influences clinical outcome that we should know how to handle in clinical practice. The international debate on the weight of contextual effect has continued to the present day without running out of steam. Several systematic reviews recently have assessed the weight of the contextual effects by comparing the active treatment group versus the sham control group, and when possible, a non-treatment group. What the different authors have observed is that contextual effects can vary from small to large effects. I report here examples from two recent systematic reviews. For example, in neck pain, we have a 38% of contextual effects for pain. In contrast, in non-specific low back pain, the contextual effect weighs for 18% in pain, 13% for function, and 41% for quality of life. And the heterogeneity in these results can be explained by the characteristics of the patient, the clinician, the condition analyzed, and the interventions considered. Recently, a new metric has been proposed to analyze the weight of contextual effect, and this is called PCE, or proportion attributable to contextual effects. And this metric ranges between two values. 0% indicates smaller contextual effects, while 100% indicated larger contextual effects. And in the slide, I left you an example of how it is measured within a systematic review. Well, despite being the subject of an international debate among scholars, this metric has been used to assess contextual effects in different clinical conditions and in different treatments. And in the next slides, I will present the findings. For example, as revealed by a recent meta-epidemiological study based on Cochrane reviews, considering different clinical health conditions, we know that the contextual effect can influence up to 70% of the overall therapeutic outcomes. Taken together, I think these findings are really interesting because they shed light on the complexity of the phenomenon we are observing and that mirrors every day the clinical practice. Analyzing specifically musculoskeletal conditions such as the osteoarthritis of the knee, we note that the proportion attributable to contextual effects impacts different therapeutic outcomes. For example, 75% for pain, 83% for stiffness, and 71% for function. But we have also data for example, fibromyalgia, where we noted that the proportion attributable to contextual effects affects for the 60% the pain, for 57% the function, and for the 63% the perception of fatigue. And the data I have shown you are just examples. I believe that progressively more and more systematic reviews will move in this direction in quantifying the effects of contextual factors in different clinical conditions, considering different types of outcomes. We have also data for the proportion attributable to contextual effects about treatments. For example, in this meta-research, the proportion attributable to the contextual effects of different treatments was evaluated. And what we can see is that the proportion attributable to contextual effects is progressively higher in treatments with higher ritual. Going into specifics, in psychological treatments, the PCE weighs for 38%. In pharmacological treatments, it weighs for 71%. And in physical treatments, such as manual therapy, it weighs for 65%. Another example of how proportion attributable to contextual effects is present in treatment was described by Chan and colleagues. The authors evaluated proportion attributable to contextual effects in non-pharmacological treatments for pain in knee osteoarthritis. In particular, they considered acupuncture and topical energy modalities, which include, for example, ultrasound, laser, and transcutaneous electrical nerve stimulation. What the authors noted was that the proportion attributable to contextual effects influences for the 61% the effect of acupuncture, and for the 69% the effect of topical energy modalities. But that's not all. With a group of Spanish researchers from the University of Valencia, we have asked what the percentage of contextual effects were for the different treatments used in physiotherapy and manual therapy for the musculoskeletal pain management. And this meta-analysis is still under review, but I want to present our findings. We have analyzed two outcomes, pain and disability. And we considered an immediate effect immediately post-therapy, a short-term effect that ranged from 1 day to 30 days post-therapy, and a long-term effect beyond 30 days post-therapy. And what we notice is that the proportion attributable to contextual effects influences all the physiotherapy treatments used in musculoskeletal pain and in manual therapy. And as you can see from the picture, the lowest PCE value is for the hands-off techniques such as the therapeutic exercises, while the highest is for hands-on techniques such as mobilization, joint manipulations, and soft tissues techniques. We also wonder about the impact of proportion attributable to contextual effects on disability. And we have to say that we have found fewer studies available. Still, from what emerged, we observed that the proportion attributable to contextual effects also play a role in disability and influences, albeit to a lesser degree, the effect of the different treatments used in physiotherapy for musculoskeletal condition. And so, trying to pull the string of this speech, what might be the implication for clinical practice? The use of contextual factors should not justify the pseudoscience, but represents an opportunity to enrich evidence-based therapies. From an ethical and deontological perspective, as healthcare professionals, it is our duty to ensure that our patients receive the best evidence-based therapy enriched by positive contextual factors. Instead, we must avoid the use of non-evidence-based therapies and, above all, not offer contextual factors negatively. And to do this, we must, first of all, be aware and trained in the use of the context. Because it is not only what we do that matters, but also how we apply the technique that has a very important role. Moreover, researchers are called upon to integrate contextual factors into their studies on force-based mechanisms and outcomes. In these regards, there are several international calls to move research in this direction. And Professor Cook, after me, will provide some suggestions helpful to consider contextual factors during the research. So, I conclude, and I want to greet you, wishing you to remain curious clinicians capable of seeing things from different perspectives and welcoming the complexity as shown in this image. Let's not just focus on the details, such as the specificity of our treatment. It is important, but it is not all. Let us always remember that the scenario in which we operate is much more complex, and both contextual factors such as the moon and confounding factors such as the stars with the sky come into play and have a role. Only if we embrace this complexity we could find new strategy for the best management of patients with musculoskeletal pain. Thanks for your attention.
Wow, terrific. As expected, very nicely done. And we have approximately 7 minutes or so for questions. So we do have some questions in the chat. The very first question we have for you is, even with standardized therapeutic intervention and settings, there tends to be a wide variability in the magnitude of a patient's placebo response. So can outcomes be individually predictable on the basis of a setting or a procedure?
Yes, that's a good question. Thank you. Yes, there was a very, very important effort to try to predict the magnitude of placebo and nocebo effects on the basis of contextual factors. And for example, they have tried to, and different research have tried to do it using, for example, the personality traits. And this type of study fails to predict the final outcome. Of course, when we interact with our patient, we should remember that the baggage that our patient put with us is really capable to influence their perception of contextual factors. For example, their previous positive or negative experiences. Their expectation can modulate and shape their perception of contextual effects. So I think that also in clinical practice and also research, we should also check for this variable before the application of every treatment.
Thank you for that. Here's another question. Do we know if there are differences between the effect of a negative contextual effect, such as a nocebo, versus a positive contextual effect, such as a placebo on a patient? Which one has a stronger effect than the other and is thus harder to reverse?
Yes, this is another important question that mirrors the clinical practice. Of course, The first and most important thing is to avoid the creation of negative contextual situation capable to trigger nocebo effects. We know from a clinical perspective that we need a lot of session with our patient to create a good rapport, a good therapeutic alliance, to create a good contextual dimensions capable to trigger placebo effects. But if we fail one session, we create a nocebo that it's really, really hard to be changed. This is a clinical experience, of course. We have data not from patient, but from laboratory setting study where different authors have shown that the creation of a nocebo, it's really, really hard to be changed. However, with several stimulation, we can try to do it. We hope that in the future, next study on patient would inform us on the importance of this topic. Thank you.
Here's someone who says, super nice talk, and indeed it was. Do contextual factors lose or increase their effect over time? Is it also known if a sort of amount of time, is there a certain amount of time it takes to actually wash out that contextual effect?
Yes. Also, these questions is really important. And we have data only from study with outcome assessed at short term. We don't have data that follow the outcome at the long term. However, what we can say is that if we are able to offer the contextual dimension in the several subsequent sections with our patient, we increase the possibility to create a good dimensions capable to impact the overall therapeutic outcomes. The really important question and the doubt is about which kind of contextual factors matters more for a specific patient compared to another one. We cannot predict it before to engage and interact with our patient. We should accept this complexity, but use these dimensions to impact the overall therapeutic outcomes.
We have one more time for one more question, and actually I received this one through text, but also through the chat. Another individual says, great topic and discussion. Are there opportunities to intentionally modify negative contextual factors as a strategy to enhance therapeutic effects?
Yes, of course. Yes, of course. I think that the most important strategy is at first to be aware about the existence of these possible negative dimensions. If we know it, we can try to assess it, and then we can try to modify it. So what I suggest is to think all the time in parallel. Adopt the best evidence-based practice, but also every time think about how we can use the contextual dimensions, our words that are like medicine, our behaviors, the rituality that is always presented within every manual therapy session we applied. We should be aware about this, because through this strategy we can avoid the creation of nocebo effects. And if a patient, for example, has a negative idea towards a specific treatment, also with the context, we can try to modify it.
Thank you so much for that. And Dr. Rossettini, thanks for staying up with us, and great presentation, great day. And panelists, or excuse me, audience, if you can give me one more minute, I want to talk a little bit about ForceNET and their pilot grants and what we're looking for with respect to contextual factors. So in these pilot grants, we are looking at traditional mechanisms, whether through imaging or biomarkers as the outcome measure. We are looking for an input of some form of force-based manipulation. So whether that be massage or manipulation or mobilization or something of that. For contextual factors, we're looking at this as a manipulating variable. So if you change the context of the therapeutic relationship, where maybe one person had a strong therapeutic alliance versus a person who has a weak therapeutic alliance, or maybe you create an environment where there's high stress versus one that's low stress. We're interested in studies like that, pilot work on that end of it. We unfortunately can't take work in which contextual factors are the outcome measure of that particular study. It doesn't fit within our pilots. Please reach out to me via email if you have any questions about that. What a day. Fantastic, folks. Thank you for our panelists. Thank you for our speakers. Thank you for those who provided the 5x5s. And once again, this will be available on our ForceNET YouTube site. Thanks again, audience, for giving us 2 hours of your day. Cheers. And if I could have our speakers and panelists stay on after this, we'll walk it through. And I'm just moving some people out right now so we can chat. So for those that aren't part of ForceNet, if you don't mind just stepping off. All right. That's all of us now. Really well done. Great job. Another really good webinar, I think. Giacomo, great stuff. I mean, we could have had more of that. That was your work is really solid. And Don, you and your colleagues, fantastic. Thoughts? I know we had a Zoom bomber.
I think we had a couple. I've been waiting for that to happen, but